If somebody wants to be a good brother, they should help their brother.
I think my brother's a superhero because he saved my life.
I have 2 boys, Vaughn and Sasun, and they are just the most incredible boys you could wish for. We found out that Sasun had SCID from his pediatrician. She called us about a week after he was born. SCID stands for Severe Combined Immunodeficiency, and it means you're born without an immune system. We had to go to the hospital and be in isolation, and I wasn't allowed to leave the room, so I had to stay in the room with Sasun for 3 months. It was very difficult.
And I just remember thinking, oh wow, man, how am I gonna explain this to Van? How is he gonna be without his mom for 2 months, 3 months, however long it is? Because I knew she was gonna have to be isolated because she was literally the only thing giving Sasun any kind of immune support was her breast milk. When they're that little, at least that'll protect them, even when they have SCID. When we came home, he asked, he's like, where's Mama and Sas? And I told him, I said, you know, Sas is a little sick. He's got to be in the hospital with Mama, and they're going to be there for a little bit. But I said, we're going to be together. And that's when I got a phone call from the doctors, and they said, hey, can you guys come tomorrow to do cheek swaps for HLA matching? And then Van asked me, he was like, who is that, Baba? And I said, that was the hospital. We're going to go tomorrow, and they're going to rub our cheeks because we're going to see if one of us can maybe save Sas. And that was when he looked at me, and he was like, no. He's like, I'm going to save the day for Sasun. And I just remember thinking, I hope you're right, little guy. And he was. Yeah, he was. When we decided to go with CBR to save our children's cord blood and cord tissue, I mean, we weren't sure if we would ever really use it. When we found out that they were a match, and I called Armina, and I was like, hey, did you hear? Like, Von's a match. He's a 100% match. And then that's when Armina said, can we use the cord blood for this? So I called the doctor right away, and I asked him, is this something we could use cord blood for? He's like, yes. He's like, this is what you save it for. At that point, we kind of felt like, man, this is magic bullet. I can't believe we have it, but we have it. So we used it.
The treatment that Sasun received gave him a future. Without it, he may not have been here today. They are just the most incredible boys you could wish for, and they love each other so much, and it just shows day in and day out how close their bond is.
I feel happy when people tell me I'm a hero.
Yeah, you are a hero.
Our hope is that our words touch some families' lives and hopefully someday save even at least one child's life.
Good morning. My name is Juliet Barker, and it's very nice to be able to chair this session today and be back in Miami. I thought this morning's session was absolutely outstanding, and I'm pleased to be able to present this morning and also be able to introduce my fellow speakers, and I think that we're going to have a really good session and continue on from the discussions this morning and perhaps get into some more controversies. So the session today is why cord blood is frequently the optimal donor source for allogeneic transplant. And as you can see this morning, that really the recent collapse of cord blood transplant numbers in the United States and really elsewhere except Japan and some of the other Asian countries, makes the title of this session quite controversial. So here are the speakers. I'm not quite sure why I'm the only one that got an MD, but I also noticed that I think this photograph is at least 10 years out of date, and I thought, wow, I looked younger then. So there you go. There's some consolation. So Dr. Politicus, my very close colleague from Sloan Kettering, will be speaking after me, and he's just taken over the directorship of the cord blood transplant program at Sloan Kettering. My close colleague from the NMDP, Martin Myers, will be speaking next, and Dr. Spitzer, who has recently departed Sloan Kettering and has taken over the directorship of Hackensack Pediatrics. Sorry, this is a little bit slow. And as you can see, Dr. Politicus is proceeding in his career, and so he has a few disclosures. Okay, so I'm going to lead off cord blood transplantation. Where are we now? As of Wednesday, assumed the position of the Director of Transplant Cellular Therapy and Professor of the Department of Medicine at Weill Cornell, which is about 300 meters. My new office is about 300 meters across the road from the front door of Memorial Hospital in New York, so that's going to be interesting. And I'll be able to do a number of exciting things there. So watch this space. But I'd like to acknowledge my Memorial Sloan Kettering colleagues, current and past, and particularly today I'm going to be promoting the work of Dr. Yanni Politicus, who you'll hear about in a minute, and also Dr. Warren Fingret, who's in the audience somewhere and I believe will be speaking later today. I also like to acknowledge many colleagues, particularly John Wagner at the University of Minnesota, and multiple other colleagues at US centers and cord blood banks around the country and elsewhere. And I have no relevant disclosures. So a lot of what I've been going to be saying today is reflecting my focus and experience on using cord blood as an alternative stem cell source for hematopoietic stem cell transplantation for heme malignancies, and as an adult transplant physician that follows. And having done this for quite some time, doing a second fellowship at the U of M, and then joining the U of M as an attending in '99, and embracing cord blood under the leadership of John Wagner, and then directing the cord blood transplant program at Sloan in 2005, and as of Wednesday, Cornell directing their program there. I have a few perspectives about cord blood transplant and the field that I was going to share today. So this is the cord blood transplant program, both what we've looked at and also the focus and and some of the achievements between 2005 and 2023, and Yanni is going to be taking over from now on at Sloan. And really we have worked at optimizing cord blood transplant practices from the get-go, as well as looking at access to transplant, particularly according to the ancestry of the patient. And more recently, Warren Fingret and I have been getting into using this data to analyze questions of disparities in access to transplant beyond just who the donor is. So the summary here reflects probably about 80 papers that we've published, something of that order. And you can see here that the variety of aspects we've looked at in terms of what can influence the outcome of cord blood transplants. And in fact, it starts getting pretty complicated in a hurry, and we've spent a lot of time trying to take the complexity out of it such that we can make cord blood transplant quite routine. So we've looked at the patient evaluation in terms of their disease, their comorbidities, and more recently their socioeconomic status and the influence of that. For the adults, we've developed a new conditioning intensity regimen that's ablative but reduced toxicity, the so-called MIDI. We've looked at and published a lot about unit selection. Marky Scaradavo and I have done a number of publications concerning transplant day management, both for peds and adults. A focus on sort of simplifying the Thor, optimizing management of the patient with infusion. The Duncan Pirtle and I published in 2014 in Blood about the importance of evaluating post-Thor quality in terms of CD34 viability and recovery. And that was all reflected based on the banking practices of the bank that the unit was procured from. We've analysed a whole slew of stuff in terms of engraftment biology, similarly for graft-versus-host disease, similarly for infections and toxicities, particularly CMV. We've looked at determinants of survival. Yanni's led the way both on GVHD as well as immune reconstitution, which you'll hear a little bit about. And then we've actually played around with a number of aspects of third-party cells and cellular therapy. So what's turned out to be the most important, and at least this is from the adult perspective, evaluating the patient, particularly for the comorbidities and their ability to tolerate the intermediate intensity conditioning, given that the non-myeloablative conditioning in heme malignancies is insufficient in terms of intensity, and the patient will either reject or relapse, and the high-dose preparative regimen that we developed in Minnesota is too toxic. So the ability to deliver this intermediate intensity conditioning regimen is very much contingent on a very accurate evaluation of the patient's comorbidities. Unit selection, particularly in terms of quality of the units as reflected by banking practices and the CD34 dose, and simplifying the Thor in terms of no wash. Ensuring that you you've delivered high viability units on transplant day, and looking at all the trade-off of dose versus match in engraftment, and we've actually found that the CD34 dose trumps match in terms of determining certainly engraftment, but also transplant-related mortality and survival in the adults. From the standpoint of GVHD, we've long since removed ATG because of its association with high mortality, but did have a gut acute GVHD signal and have worked a lot with adequate prophylaxis and been able to mitigate that to a large degree. The biggest problem with infection was CMV in the adults, and the letermovir prophylaxis has been an absolute game changer in that regard. In terms of determinants of survival, the the infused viable CD34 dose has really stood out, and that sort of dovetails back to the importance of ensuring the high-quality unit. And Yanni will speak to the immune reconstitution, which we've seen very good immune reconstitution in the vast majority of patients. So the value at Sloan has been that we've been able to extend access with greater than 50% of our patients being non-European in ancestry, at least either fully or in part. And this progressive refinement of transplant practices, which has really been achieved by sort of just slogging away at analyzing and trying to sort of refine how you're doing the transplants in terms of all these factors, and also developments in the field such as the letermovir. As I said, that's been a game changer. And also sort of simultaneously sort of recognizing and addressing the challenges for underserved patients, because the cord blood transplant recipients are sort of enriched for these patients that are underserved, particularly the African ancestry and non-Black Hispanic patients. So you could see here that Yanni's working on writing up this data as we speak, a recent analysis of 25 patients. So it's very recent, and the median follow-up is only 17 months. But you can see here for recent young and middle-aged adult double cord transplant recipients, and you'll see here the median age is a bit younger than what we've previously published at 39 years, and the units, the vast majority of the units that went into the transplant, into the patients were either 4 or 5 out of 8 matched to the recipient. And you can see here we've absolutely been able to mitigate transplant-related mortality, which was previously the biggest problem for our patients. So these are all double unit grafts. The graft failure rate 0, the median day to ANC recovery is day 19. There's a high incidence of grade 2 acute GVHD, which may actually be good. The incidence of grade 3 to 4 acute GVHD, which previously was unacceptable, is now less than 10%. And as I said, the 1-year transplant-related mortality thus far is 0. So despite these excellent survival results in expert centers that have dedicated to cord blood, such as Sloan Kettering and multiple others that we've been hearing about at these meetings, cord blood transplantation has declined, and I would say actually it's sort of collapsed. Pretty much, or used as a last resort. So is this a problem? And I would argue yes. And it's a problem from the standpoint of health equity, but it's also just a problem because of the fact that if you, at Sloan we've certainly made the cords very routine, and more recently, the barometer is when you walk onto the floor and the nurse practitioners will say, actually, we like the cords, like bring more cords in, because of the fact they engraft, they just sit around for a while, but they're not as sick. And that's basically because of the fact that they don't get CMV because they're on otemivir, and they don't, the vast majority are not getting severe acute graft-versus-host disease of the gut. So at any rate, I'll give you this example, and I think that Filippo was talking about a case during the break similar to this, and these patients are out there, and I think this is a problem that we don't have as a field sort of finger on the pulse in terms of how big this problem is. So this is a patient of non-European ancestry, an underserved minority patient with acute leukemia that was cared for at an outside institution. She had no available 7 or 8 out of 8. Well, she had no matched siblings. She had no matched 7 or 8 out of 8 matched unrelated donors. She had donor-specific HLA antibodies to her only haploidentical donor, and there was some issues in terms of availability of the haploidentical donor. And so basically she had no adult donor. She'd previously had breast cancer and had combination chemotherapy for that and developed a treatment-associated MDS. At that point, the molecular analysis of her disease would dictate that she should be transplanted immediately, and if she'd been at Sloan, that's what we would have done. She rapidly failed the therapy at the outside institution, evolved to refractory treatment-associated AML. They pursued adult donors without success. Therapy continued and fairly advanced in her course, sort of really, when she had completely refractory leukemia, she was referred to MSK, and she had very good domestic units that could be shipped within 72 hours, but she had refractory leukemia. So we admitted her under the leukemia service, and she underwent further extensive therapy and finally received her cord blood transplant with a delay of 7 months from the date of indication, and she died of toxicity on day 6, which was really not related to the cord. It was related to the fact that I think as the transplant field, we failed the patient. And that will be recorded as a cord blood death. And that's it. So I think that we need to analyze the impact of delay to transplant on survival, and also how many patients by ancestry are not transplanted at all because of the fact that they fail the availability of any adult donor. And also, we talked about the HLA antibodies this morning, and we have the worst HLA antibody burden that we have seen have been in minority patients that are female and multiparous. And Warren and I are writing that up as we speak. So is there an explanation for the decline in cord blood transplantation? The answer is yes. And I thought Leyland's comment about being in purgatory was a very good setup for my talk. So there's really been 10 problems in cord blood transplant as the way that I see it, and this is a busy slide, but I think it's probably the most important. And I think that this is also, I would say that if you get up and point some of these things out, you can get yourself into real trouble and become extremely unpopular in a hurry. And, you know, it is what it is, but I think some of these things we have to address for the field and for the patients. So there was a lot of excitement in relation to cord blood expansion, and there continues to be. However, I think that has the unintended effect of an impression by many transplant centers that you cannot perform cord blood transplant without expansion. But if you get up and say that, they assume that you're criticizing expansion, which is in fact not the case, but we have not adopted expansion at Sloan over the last 20 years, and we get the grafts in. There were major problems with the BMT-CTN non-myeloablative double versus haplo trial. Then investigated outdated conditioning, did not pursue optimal cord blood transplant practices. In retrospect, the poor cord blood transplant outcomes were accepted as the best possible. The emphasis was that the haplo was better despite the fact that the results of both were poor. So, you know, that's a problem. From the standpoint of graft selection, there's no mechanism to ensure that the best cord blood units are selected. The good outcomes in experienced centers have largely been ignored, and there's less marketing opportunities. There's no major profit in cord blood banking, and there's also an assumption that mismatched unrelateds will resolve racial inequities, and that's certainly not the case. There's a lot of issues in terms of politics and money, is what I would argue. There's been a big polarization in the field with a focus on early cost, not the long-term benefit. These dynamics have translated to a drop in cord blood transplants, and then you have no funding to ensure optimized cord blood transplant operations and training at the transplant centers. The timing of the cords is often last resort, and that's not ideal. Warren Fingert and I have just pulled out an attempt at pulling out the socioeconomic status of the patients, and certainly the cords are enriched for lower socioeconomic patients, as are the other mismatched adult donors too. And then there's unique biology going on that Yanni's going to talk about, but there's no funding to study that anymore because of the fact that the cords have sort of not the sort of sexy, shiny object anymore. So that's really a problem because of the fact that we've been able to extend transplant access with robust graft-versus-leukemia effects. We've also been able to show that the speed to cord blood transplant's been unaffected by the patient ancestry, which is certainly not the case for adult unrelated donors. So are there potential solutions to this which would help both the patients and the field? And the answer to that is yes. And so I'm just going to burn through these in terms of acknowledging the limitations of the access to adult donors, incorporating cord blood transplant as a routine alternative from the search outset, as well as mandating distribution of optimal units. I think this is extremely important and is not being done. Understanding the determinants of cord blood transplants at a transplant center, and I think that we need to create a national network of collaborating centers to optimize cord blood transplant practices. So what about acknowledging the limitations of adult donor access? So we really need to be doing what the intention to treat. So not just looking at, okay, this patient was transplanted with this conditioning, with this disease, with this graft, and this is what happened. But we've got to look at, from the diagnosis, which is that the allograft indication, start the clock there and then watch what happens. And certainly Warren's going to be talking today about our data in terms of the problems of non-European ancestry patients, particularly the patients that are either African or non-Black Hispanic. The unrelated donor availability is a very major problem and hasn't been adequately addressed. As I said, the speed to transplant for the unrelateds is very delayed. The referrals or outside referrals to the centres are also delayed, but it's not just that, it's the actual procurement of the donor is delayed for the adult donors. And these patients are more likely to receive suboptimal unrelated donors, and that also hasn't been sort of adequately acknowledged. And the number of patients that do not make it to transplant due to adult donor delays, I think, is unknown. Warren's going to go through this afternoon, but he and a Sloan team diligently, for 455 recent adult patients at Sloan, went through the chart. None of this was in our database, and pulled out the details of 3,843 unrelated donors that we went after for 455 adult patients, and basically set the clock that we went after these unrelated donors and how many of them ended up actually available for donation, and the answer is less than 50% overall, but the data is extremely troubling for the African and non-Black Hispanic patients, which I'll get Warren to talk about. So I think that what we have to do is that we have to improve the efficiency of patient and donor assessment, and we need to facilitate having cord blood as a potential alternative, but only allow transplantation with cord blood with a suitable graft. So this is sort of our algorithm ability to predict whether or not the patient's going to have a matched unrelated donor has been very much aided by the search prognosis algorithm that Eric Davis has led the development of, and we just published that in TCT a few months ago. And our search coordinators can basically tell within half an hour whether or not the patient's going to have a matched, meaning 8 of 8 unrelated donor. And we also take into account the availability by the patient ancestry. And then we look at all alternative donors. And I think we have to, if there's multiple options, consider the optimal donor, which Warren and I published a paper about last year. But I think everything has to be on the table, because some patients will have very good cord blood grafts, and particularly for the patients with very high-risk disease, we can take them to transplant extremely quickly. Whereas some patients have poor or no cord blood units, and those patients should not be getting a cord blood transplant. Some patients we have had, for example, immigrants from the Caribbean that have a high body weight, and there's no cords, there's no haplos, and we need mismatched unrelateds, and you've got to run down the match grade and pursue a lot of donors to get one. So I think that this is complicated but needs to be done. You also need to understand what is needed to perform a cord blood transplant at a transplant center, and there's a lot of politics here, and this is not necessarily science. So you need to get the okay from leadership and administration to be able to perform the cord blood transplants, and the cord blood has to be incorporated into the clinical and research priorities of the program. You need a dedicated faculty to direct cord blood transplant and be the cord blood transplant sort of local champion, and if you don't have that, it will not occur. And that person or people will sort of facilitate the fact that the cords occur and are an option in the quality of those transplants. And then you need an army of people in terms of allied healthcare professionals, and also the capacity, because the patients need to be seen more frequently early post-transplant when they're discharged. So if the transplant center doesn't have the bandwidth in terms of space and staff, it's not going to happen. And that's basically the bottom line. And I think that we need to create some type of national cord blood network of collaborating centres with a mission to optimize cord blood transplant practice and increase activity to be able to rescue cord blood, the collapse of cord blood transplant. And if you bolster up the transplants, you'll bolster up the banks, because then the transplant centres will start utilising the units. And I think this is an issue of health equity, and there's data out there that we don't know about that I think there are major problems still for the minority patients, some of whom are not getting to transplant because of problems with adult donors. So I think this warrants real discussion, and I think the value of this would be that all of a sudden it would be put cord blood transplant back on the map, because of the fact that it could be, the field tends to pursue shiny objects. So if Sloan just says, okay, do this, well, it's like, who cares, because we don't listen to Sloan. And the cords have transplants have become this boutique sort of practice, such that Seattle does this, Sloan does this, and one other center used to do this, but now they don't do them, and it sort of recedes, and then it's not sexy, and then the juniors don't want to do cord blood transplants because of the fact that it's not the sexy thing anymore, and it will be potentially suicidal for their academic career. And you have to understand within the transplant centers that you have to be able to survive from an academic standpoint, because otherwise you won't progress and you won't get promoted. So, but if we unite, then we may actually have a decent chance to be able to put cord blood transplant back on the map and rescue the field. So, and lastly, I think that we also have to concentrate on improving allo transplant for all, and this has got something for everyone, so it's not controversial, and it's very overdue for the field to address. And so this is regardless of donor. So the characteristic determinants of transplant outcome that are now analysed, and you'll see in the publications, is the biology of the disease, the patient characteristics, like how they're transplanted with what prep, what donor, what immunosuppression, and supportive care gets less of a sort of emphasis, but it's PTCI, yes, no, haplo versus mismatched unrelated, yes, no, non-myeloablative conditioning versus ablative, yes, no. But there's way more to the story. So there's the access to transplant and the speed to transplant, shown here in green. And then there's a socioeconomic status of the patient and stability, the medical debt, the access to expensive meds, which we've certainly tackled in a big way at Sloan for some of these patients. There's caregiver support, there's health literacy issues, there's trust in healthcare that we've had some issues with for some of the patients that agree to the transplant and then suddenly don't agree with the ongoing sort of need for medications, for example, which translates to medication adherence. So we need all stem cell sources. We need more capacity, particularly space and staff, and you need big multidisciplinary teams. And I always say, whatever we've got, we need more. And post-COVID, that doesn't necessarily go down well. At Sloan, we've had a big team, multidisciplinary team, overseeing the medication access and adherence. And we need very much more to get into debt evaluation and financial support for the patients. We need regional outreach to get the patients into the expert transplant centres, and we also need to reform the insurance setup in the United States. And on that note, I'm going to hand it over to my colleague, Dr. Politicus, who is going to be taking over from me at Sloan Kettering. And it's a pleasure to introduce him. He's a very close and lifelong colleague, and he's going to be talking about immune reconstitution and biology. And there's your clicker.
Good morning, everyone. I would like to thank Dr. Barker for her kind introduction and her invitation to present in this session with a rather provoking title. I was asked to cover in my talk the topic of cord blood-derived graft-versus-leukemia effects and associated immunobiology, which is a topic I have a major interest in, especially considering that it is one of the strongest attributes of cord blood. These are my disclosures. So I will split my talk in two parts. In the first part, I will cover some clinical data that I hope will prove to you that there is a robust GVL effect and low relapse rates with cord blood, at least in certain transplant settings. And in the second half of the talk, I will try to address some of the potential immunobiological mechanisms for this observation. As early as 2010, there was a combined analysis between the Fred Hatch and the University of Minnesota comparing cord blood recipients with recipients of matched-related, matched-unrelated, and mismatched-unrelated donors that demonstrated a low relapse rate in those who received transplantation with a double cord blood graft. These findings have since been corroborated in several other studies. Here I have included a paper from Sloan Kettering, where again we observed low relapse rates compared to 7 out of 8 and 8 out of 8 unrelated donors. And I believe most of the people in the audience are familiar with Filippo Milano's paper in the New England Journal that showed the same findings. One point I will make, however, is that in many of those cohorts, a lot of the patients received double unit grafts. What about MRD? That got a lot of attention when Filippo published his paper in the New England Journal of Medicine showing that cord blood had major benefit in patients who were MRD positive by flow at the time of transplant. There are since more data addressing the same question and showing largely similar findings. Here I present a figure from a recent analysis in the UK and Ireland in MRD-positive pediatric patients. Again, there was benefit in recipients of T-replete cord blood compared to patients who received non-cord grafts. And the panel on the right shows, or I should say, is from a paper that has not received a lot of attention. It's data from the University of Minnesota, but it has the novelty of splitting patients both by MRD and graft, but also by conditioning intensity. And as you can appreciate, it is only in the patients who received ablative conditioning that there was benefit in those who had MRD positivity. So conditioning intensity may matter. At Sloan Kettering, when Juliette was still there and under her mentorship, we actually took a look at our data. This is an analysis of progression-free survival in patients who received double unit grafts versus sibling or 8 out of 8 unrelated donor T-cell depleted transplants, which remain the preferred platform at Sloan Kettering for matched donors. And as you can appreciate, there are two important findings here. Firstly, there is high progression-free survival in cord blood recipients compared to siblings, but also, especially in the MRD-positive patients, the survival is not different when they receive cord blood, whereas there is inferior survival when they received adult donor grafts. What about refractory patients? There are two recent analyses from the Japanese registry. The one on the left is demonstrating a comparison of cord blood to matched-related donor transplants, and on the right there is a comparison of cord blood to haploidentical donor transplant recipients. And again, you will appreciate that there are lower relapse rates in patients with clearly high-risk disease in those who received cord blood. But I would also like to point out that in the comparison to the haploidentical donor patients, again, there was an effect of the conditioning intensity. So again, the conditioning intensity may matter in terms of being able to observe the strong GVL. I also have a couple of slides on the comparison of single versus double unit outcomes. These are figures from the randomized European study of single versus double. And although in the entire cohort there was no appreciable difference in single versus double with regards to relapse, although relapses tended to happen later in the double arm, there was indeed a reduced relapse risk in patients who received a double unit graft in the ATG-free arm of the trial. I will point out, however, that in the BMT-CTN 0501, there was no difference in survival, so it's hard to know exactly what to make of this data here. However, there are other lines of evidence supporting that a double unit graft may have a lower relapse risk. This is an older paper on the left from the University of Minnesota demonstrating lower relapse risk with a double compared to the singles. And then on the right is a post hoc analysis of the European randomized study that I just showed you on the previous slide, but this time focusing on the MRD positive patients. And the MRD positive patients, a lot of those were pediatric or young adults, so a lot of ALL here. They did seem to benefit in terms of reduction in relapse risk when they received the double unit graft. So trying to summarize the clinical data that I showed you so far, I would say that reduced relapse risk with cord blood has been reported in several, mostly retrospective cord blood series, but not in all of them, and there are certainly many confounders. As a general observation, I would say that reduced relapse risk pardon me, has been more commonly reported in double unit cord blood transplantation series, and also in patients who received ablative or intermediate intensity conditioning, and certainly in patients who did not get exposed to ATG. So in view of those clinical findings that would suggest robust GVL with cord blood, several questions remain unanswered with regards to the potential mechanisms of the GVL, which I will try to cover in the second part of my talk. This is a relatively busy slide trying to outline the potential mechanisms that may explain this robust GVL cord blood-derived biology. I'm not going to spend too much time on this slide. I will present it again at the end of the talk as a summary slide. But the point I want to make here is that it is very likely that the mechanisms are multifactorial, and several of those mechanisms may be contributing. I also want to point out that in general, we can break down those mechanisms in two categories. On the top, you will see that there are factors that are specifically related to the immune reconstitution and the unique immune properties of cord blood neonatal T cells. And then there are a number of other mechanisms that are more related to HLA disparity and HLA, an ability of the graft to recognize a mismatched leukemia. So I will present a slide or two for each one of those mechanisms, and then we'll come back to that slide for the summary. To address the first potential mechanism, this is an elegant study from the UK, where they used an ABV-driven lymphoma mouse model, and they infused those mice with either cord blood-derived T cells or T cells collected from the peripheral blood from adults. As you can appreciate, there was superior survival in the mice that received cord blood-derived T cells, and the paper goes into the potential mechanisms for this observation. There was superior infiltration of the ABV lymphoma tumors by cord blood-derived T cells, and there was also TC1, TH1 skewing of the anti-tumor responses. So that would suggest unique immune properties of the cord blood T cells compared to the adult T cells. Bollens has published several reports now showing that in the absence of ATG or low ATG exposure, there is robust CD4 biased T cell reconstitution in pediatric patients. Under the mentorship of Dr. Barker, we published the same findings in adults at our center, but the fact that there is no skewing of the CD4 to the CD8 ratio and there is early increase in the CD4 T cells may have an impact on relapse risk because at least in AML patients, there has been an observation that those patients who achieve early robust CD4 T cell reconstitution, which is defined as more than 50 CD4s before day 100, there was a significant reduction in relapse risk, as shown on the panel on the right. Moving on to the HLA-related mechanisms of GVL, as I'm sure everyone is aware in the audience, we accept a higher degree of HLA disparity in patients who undergo cord blood transplantation, and the number of the mismatches may play a role in this reduction in relapse. In general, with increasing degrees of HLA mismatch, there is potentially more GVHD, but also a decrease in the relapse risk. On the right, I'm also showing that there is actually benefit in terms of overall survival, at least in the Japanese registry data, with patients who develop grade 1 to 2 acute GVHD, which may be related to the associated GVL. I don't have the time to go into more detail about the HLA, but there is more elegant data coming out from large-scale analysis from Japan that the locus of the mismatch may matter, specifically class 2, and there is certainly data to support that DR and DP mismatches may indeed be beneficial in terms of reducing relapse risk. Now, the fourth mechanism is quite interesting, and for those that are not very familiar with the IPA and NEMA terms, this graph is quite useful. The baby inherits one haplotype from the mother and one from the father, but there has been the hypothesis that the mother during pregnancy gets exposed to the inherited paternal antigen and mounts an immune response against those antigens. Those T cells, probably T cells, but there could be other lymphoid factors or immune factors that recognize the inherited paternal antigen, may cross the placenta and may be present in collected cord blood units. The first indirect evidence that this may play a role was done by Van Rood and colleagues in an analysis from the New York Blood Center database, where indeed they showed that patients transplanted with units that had no shared IPA, had shared IPA, so in principle there were maternal T cells in the graft recognizing the shared IPA with the graft, had lower relapse risk. And this was independent of GVHD, as the GVHD was not increased. More recently, a small but very interesting study from the Hatch actually was able to demonstrate that in about 1/5 of patients in this analysis, they were able to find maternal microchimerism, so those like T cells that we think may have some ability to recognize the IPA antigen, and there was no relapse in that arm and improvement in overall mortality as well, with the caveat of the small sample size. Moving on to the fifth potential factor, this is specific to the graft versus graft interactions in the setting of a double unit graft. This is an elegant paper from the Netherlands, where the investigators were able to show that when the losing unit is mismatched to the winning unit, but shares class 2 alleles with the patient, there is an immune response from the winning unit against those class 2 alleles. And so the presence of the losing unit may actually potentiate the GVL due to, in the setting of the immune-mediated rejection of the losing unit. I don't have the time to go into the biology of this, but this is certainly a very nice article highlighting a novel mechanism that could potentially explain the GVL seen with double unit grafts. And finally, these are unpublished data that Luca Vago had shared at the conference and kindly provided the slides to us some time ago. This is the topic of the HLA loss, meaning some of the relapses, especially in the mismatched setting, may be attributed to the fact that the leukemia cells may be able to lose the mismatched HLA and therefore evade immune surveillance from the graft. When Luca Vago's group analyzed the incidence of HLA loss as a mechanism of relapse across different graft sources, there was evidence that evidence of HLA loss in haplo and mismatched unrelated donor grafts, and for some DP mismatched patients who received data-to-weight grafts, but there were no cases of HLA loss in cord blood recipients. And a potential explanation for this is that in contrast to the haplo, where the whole haplotype can be deleted, and in the setting of the uniparental disomy, the leukemia cells could evade immune surveillance, in cord blood, where we still have a lot of mismatches, oftentimes those mismatches happen in trans, not in cis. So there is no benefit to the leukemia cell to delete one of the HLA haplotypes, although in theory there is still the potential for epigenetic downregulation as a mechanism of immune evasion. So coming back to this slide, I think I provided some data to suggest that all those mechanisms could potentially be contributing. Certainly more work is needed to establish which ones may be the more important ones, or which ones may be the ones that contribute the most. And understanding this GVL biology could potentially benefit the field because it will improve the selection of cord blood units, especially in patients who have high-risk disease. So in summary, I hope that I have shown you enough data to convince you that cord blood transplantation is indeed associated with robust GVL effects. So to answer the question, like the title of the provoking title of this session, I do think that cord blood may be an optimal graft source, especially in patients who have high-risk hematologic malignancies, including those with MRD or those with refractory disease. I will also point out that to be able to harness the GVL effects, we need optimal practices, and we certainly need to maintain the TRM low, so adherence to the guidelines that have been published will be important. And certainly more investigation is needed to further evaluate the mechanisms of cord blood-derived GVL biology, because then that could lead to the rational design of clinical trials, specifically harnessing those advantageous cord blood effects. With that, I would like to thank Dr. Barker for the invitation to participate in this session and for her mentorship over the years, and I do look forward to continuing our efforts to understand this immunobiology moving forward. I think I have covered enough on the adult side. I will now hand it. Oh, pardon me. Dr. Myers will take over to talk about the inventory, and then Dr. Spitzer will talk to us about pediatric CDC.
Okay, thank you. Thank you, Giannis. Thank you, Juliet, and the organizers for inviting me to speak. I believe my colleague Abir Madbouli was invited, but she doesn't like travel. I love traveling, and I am proud to be a member of this society, because any society that would give Donna Reagan a Lifetime Achievement Award is the one that I want to belong to. So I'm going to talk about the inventory, its growth and characteristics. I don't know if I'm going to add a lot to the question of identifying when cord blood is the best product, but I have some ideas on that. I don't know if I have a lot of results. But I was going to start with the WMDA, another organization I'm proud to be a member of. And this is the global cord blood availability worldwide, a little over 800,000 units globally, 287,000 or so in North America, and generally that splits about a third in Asia and Oceania, and about a third in Europe, and about a third in the Americas. The addition of new units follows this curve, which I think people in this room are generally aware of. I don't know what happened in 2019, but I think generally this is, there's been sort of a slowing of adding to the inventory. But contrary maybe to, I guess, the perception locally, worldwide, things really, in terms of shipment of cord blood units or utilization for transplant, things are actually relatively flat, even though obviously that is largely due to the activity in Japan, Asia generally, but specifically Japan. So the numbers in each of these WHO regions is the number of cord blood units provided and used for transplant in that region. The arrows between the regions are representing the international exchange, which, is about 20%, and I think took a little bit of a dip during the pandemic, even further. So looking at the national inventory, I started working at NMDP in 1996, and there was this new thing called cord blood that we were trying to fit into our database and use for matching. And you can see, that curve of this is the number of cord blood units banked per year. And then I colored in blue those that are through the NCBI program, which is, a little less than half. But you can see as the years went on, that formed more of the majority of the units. When you look at the inventory, one of the main characteristics is the total nucleated cell count. And in this graph, these are density plots. So overall, 4.2% of the units in the US inventory have been shipped or used for transplant. But the mean TNC of those that were shipped is 187 times 10 to the 7th, whereas the mean of the not shipped is 122.9. Okay, that's also not news to this group. CD34, which is more recently added to the guideline, it shows a similar pattern where almost the mean is almost double of the shipped units. So I wanted to try to get a visualization of the 282,000 cord blood units in the US inventory. So there they are. The x-axis is TNC and the y-axis is CD34, and it's on a log-log scale so you can see the whole group. And just to kind of illustrate the barrier of cell dose as if it was sort of a new thing, consider a 15-pound patient, or at least someone who claims to be 215 pounds. And in the vertical line is the TNC threshold. So the units to the right of that would provide a dose of 2.5 times 10 to the 7th per kilogram of a roughly 100 kilogram individual. And on the y-axis, the CD34 threshold, as the recent guideline led by Giannis recommends a single unit transplant. So that leaves this upper corner. When you look now at the units that have been shipped, they're of course skewed in the direction of high TNC, high CD34. What I guess I didn't realize, and there's lots of different ways to quantize this, but of all of the units ever banked in that upper quadrant, about half of them have been shipped. So when it comes to answering the question of how big should the inventory be, it's really important to keep in mind this phenomenon, because it's sort of like it's been picked over. There's been this use, and not an insubstantial fraction. If you just look at the TNC dimension, it's 36% of the units above that dotted line have been shipped, and on the CD34 dimension, maybe because it's newer and they're correlated, it's closer to 29%. Okay, that's single cord, and I know there's double cord, and there's expansion, and there's new cell therapies, and we're going to hear about all of those during this meeting, but I still want to talk about matching. I'm also a member of the American Society for histocompatibility and immunogenetics. And if you're already convinced about this next point, you can sort of rest your eyes for 4 slides. And if you're not, then I would like to argue with you about alleles versus antigens. And maybe this is old school, but I think Steve showed some data this morning, very recent data, and I think these studies from Mary Eapen are sort of definitive around the importance of allele HLA matching in the selection of single cord blood units in adults and pediatric, malignant, non-malignant. But I think there's 3 reasons, and the science is only one of them, why we need to remove the X out of 6 AB serology definition from the guidelines. The current guidelines have them. The current EBMT guidelines have this. And the first reason is the science. The second reason is it's even worse than that. It disproportionately disadvantages non-white patients. And so to demonstrate this, I did a simulation where I was selecting HLA types at random that were 4 out of 6 in the antigen AB definition, but sampling from these 5 different patient populations, and then comparing what the X of 8 corresponding match grade would be. And 80% for the whites are 5 of 8 or 6 of 8, but not so for all of the minorities. And when you extend this to 5 of 6 and 6 of 6, I mean, look at that number. 85.7% of the X of 6, 6 of 6 in the antigen AB definition are 8 of 8 alleles, but it's less than that, less than half for Asian and African. So that's reason number 2. Even in Florida, we're allowed to say you shouldn't disadvantage minorities in healthcare. And the third reason is that I'm lazy, like all programmers, and I don't want to have to deal with the really messed up definitions of serology and having to explain to people why 2 alleles that start with B40 are an antigen mismatch to each other. The WHO nomenclature committee met yesterday, and for the first time in 32 years, they're going to expand the antigen categories, hallelujah, to deal with all of these things that the immune system has known about, but a very European-biased nomenclature has avoided. So, okay, end of rant. And if you were all already convinced, then I apologize. So when we look at matching, we don't just start with what's the match rate for patients looking at cord blood, but we model it in terms of a search strategy, and this is one that is usually where we start, where you are looking at a patient who is searching for first an unrelated adult donor and an 8 of 8 allele match, and if that can't be found, then moving to an 8 of 8, 7 of 8, 6 of 8, 5 of 8 cord blood. And I know 4 of 8 is the standard, but so far we haven't modeled that. And so across 21 different ethnic groups, sorted by the overall match rate, on the left side adults and the right side pediatric patients, you see in red the match rates for the donors, and then in the different shades of green, the 8 of 8, 7 of 8. I'm sorry, you don't see the 8 of 8 because it's so tiny. And this is part of the problem. Once you don't have an 8 of 8 adult donor, you're very unlikely to have an 8 of 8 cord blood. But you see the 7, mostly 6 of 8, 5 of 8. And equalization happens more for the pediatric patients, as I think is sort of the success story of cord blood. We also look at a cord first type of strategy just to get a sense of the matching. We've also done different iterations where you look at an 8 of 8 and a 7 of 8. But generally the story, what's interesting is the top of these curves is the same, whether you included that adult donor or not. So certainly 8 of 8s can be found. Now you can see the yellow, and there's some, but it of course is specific to those groups that are still overrepresented or at least have very, very common HLA types so that 8 of 8s can be found. Patient weight is of course a factor in this whole cell dose story. So on the left are violin plots, because I love violin plots of the blue are the 4 main ethnic groups in the US, African, Asian, European, and Latin American, and then in the green is the pediatric, and we're modeling this as 20 and older as an adult, which is to me a little bit of a strange place to make the cut. But you can see that line is at 75 kilograms, and on the right, this is not a great way to visualize it, but when we do the modeling, for historical reasons, we look at all of the patients, let's say the adult patients in blue, and we break them into deciles. So these are equal-sized buckets, and then we say for each bucket, for patients in that bucket, what fraction of the cord blood inventory would provide a dose, in this case 2.5 times 10 to the 7th. And in blue, you see that fraction is very small. It's highest for the lightest adults, so to speak. And as you get to the heavier, it goes almost to zero. I think overall it's less than 5%. But even for pediatric patients, this comes out to be close to half. So there's that dose barrier ends up being obviously a big deal. In double cord, of course, is one of the many strategies to overcome that. But we've also run the models, because they're models, you can try things. What if you just took that out of the equation? So in orange, and this is 8 of 8, 7 of 8, and 6 of 8, matching when you remove, well, the red is the 2.5, sorry, the red is 3.0, the blue is the marginal benefit of lowering that to 2.5, and then if you eliminate it altogether, you get to, even at 6 of 8, some really nice match rate levels. And so we summarized this in a abstract at ASH several years ago, but I think the story is still generally the same, that if you look at 6 of 8 or better, 6, 7, and 8 of 8 allele match with the current inventory, you're seeing at a dose of 2.5, and this is before the CD34 was part of the story, but still, I think match rates that are ranging for, as high as 90% children for all patients. And if you take out TNC, then you're at 90% for almost every population. Still, African American is the lowest, but this is sort of a optimistic way of portraying the match information, but I think it's, just puts more focus on that question if TNC were not a factor. We also, with this modeling platform, can project into the future, although it's very difficult given the dynamic future that we've seen unfold since 2016, I guess the point where we modeled. We took the previous year's recruitment and just assumed that continued, and then you get this kind of linear growth, which is, I will just say, modest at the level of 6 of 8. In this case, it's a dose of 3. But okay, so the question really is, how many units do we need? I was around when the Institute of Medicine commissioned this study by some economists who had only worked with banks that store money, not banks that store cord blood, but they're banks and they're economists, so they know how to do this stuff. And they wrote this paper, they did an analysis for the government, and then published the paper. And at this time, they were just trying to get to what is that number that we can put in front of Congress to say you should go to this number. And that number was 150,000, although the way it was worded was saying inventories greater than 150,000 are not cost effective. But maybe the positive way to say that is that it's cost effective at least until 150,000. And I think we know a lot more than what we knew in 2006 and 7. Outcomes have improved since then. So I don't read this as, because we've already doubled that number, right? So I don't think this means stop at 150, but it means, you're good to at least 150. And then about 12 and a half years ago, we did some modeling around this question of TNC. We just did a simple simulation where you took this TNC threshold for banking a unit and some assumptions about the cost of collecting a unit and not banking it, and banking it, which I'm sure are open for debate. But we sort of swept the threshold across the spectrum from 0 up to, looks like 250. And we found that sort of the overall financial viability of the system was maximized at a threshold of 155 times 10 to the 7th. And we had a big meeting in Chicago. Maybe some of you were at that meeting, and we all had breakout sessions, and we all did discussion about this finding. And then everyone just went on living their lives, because as I've come to start to appreciate, but not as much as I probably should, that's hard to do. You can't just say, raise the threshold. But from a math standpoint, that's the answer. So these two European economists, Jeremy Magellan and Gregory Katz, organized a study that did something sort of similar, and they had a provocative title. And they looked at 4 different strategies for setting a minimum TNC threshold. And of the 4, the one that they recommended was 179 times 10 to the 7th. And the way they worded it is that threshold would allow banks to remain solvent, which I think is, and implying that collapse was imminent if that weren't the case. And then, of course, the Rand report. Who doesn't sleep with this one under their pillow? Actually, Rand is it's full of, it's really humbling to have some organization come write about something that you've been studying your whole life and have it be actually so much better than anything. So I really do like this report. Challenges to the sustainability of the US cord blood system. Okay, they took NCBI, non-NCBI, so whether you're getting reimbursed or not, and whether you take 1,300 or 3,100 as the sort of extreme range of the cost of banking a unit, they're still saying you need to move in this analysis, well, in addition to increasing the diversity of the national inventory, which is an important point, they also said increase the minimum TNC, especially for non-minority, and in their analysis, depending on whether you use the high or low number, it's at least 150, probably 1.75. And then maybe most optimistically, this group of economists who are, none of whom are actually involved in transplantation, but are sort of fascinated with this domain as a sort of an outlier in this space of economics, did a cost-benefit analysis, and the details are all in this great paper in the Journal of Risk and Uncertainty. But they are essentially taking what economists do, the quality-adjusted year of life and the dollar value that represents, and then looking at the cost of the program. And overall, they say, in the US and for the world, the sum of the marginal benefits and an increase in either the adult registry or the cord blood bank exceeds the marginal costs. And it exceeds it by a lot. Now, okay, but haplo, we heard this morning, haplo unrelated, haplo related are going to compete. To me, that just means, you know, these margins might get a little bit closer, and maybe to me, it all puts more pressure on the TNC threshold. But to answer the question that the title, it seems to be asking, I believe the answer is yes. The benefits outweigh the costs, and we need to replenish these high TNC CD34, and yes, raise the TNC threshold for banking and reimbursement. You know, again, easy to say, possibly hard to do. This is all just given the current use, and then as, you know, I was talking about this issue with some people at ImmuneBridge, and Jesse Kotari here is giving a talk on Sunday. I can't wait to see because, and Colleen Delaney will also talk in that session about the use of these smaller units for other kinds of therapies, and we heard about that this morning too. So I think this is saying, even without that, we should grow the inventory. I think those new uses are pretty exciting and will only, I think, increase the demand for the whole system. So I'm going long on cord blood. And I think the US government should too. So, but how do we refine these models? The European paper talked about a utility score, and we've been working on models like this for adult donor, but I think in cord blood it's even easier because you have all the data up front. With the adult donor, you sort of acquire data through the process, and it's but we've started working on machine learning models to predict which units will get selected, and of course, these Shapley plots that show the relevance of these variables. Yes, TNC is at the top, but you know, okay, registration year is negatively correlated with a cord being selected because you have to be on the bank for a while before enough patients see the cord, and birth year is registration year. CD34 shows up, but HLA genotype frequency is one I'd really like to understand more because it does look like rare, less common HLA is more likely to get utilized, which I think makes sense given that it's usually a secondary and generally minority. But I think there's more here that we could look into. And the other thing I'd love to see a model for is can we predict which mothers will give birth to a baby with a cord blood that has a high TNC and CD34 count? Are there any markers that we could use to try to predict that? That's a question. So yeah, new cell and gene therapies. I'm not going to talk about them except to say I'm a big fan. I think we have challenges, and we're going to talk about this later in the meeting too, about the consent language and which units can be used. So by one reckoning in the US inventory, only 16% have consent language and licensing such that they could be used for off-the-shelf therapies that are sort of in a one-to-many, like iPSC or banked NK cells. And when it comes to iPSC, which is one of the popular uses of cord blood, certainly in Japan, this has become sort of there's been a lot of growth in iPSCs derived from cord blood, and they're focusing on homozygous HLA, at least across AB and DR. And so I took a look in the US, and we only have 1,190 out of 282,000 units. That seems like a really low number. And it differs by bank, which may be because of population structure for banks in urban versus rural or less urban areas, or with different ethnic background. But overall, I think there's a question that the field is going to need to face, which is what's the economic value of a homozygous unit, and is it the same as a heterozygous unit, given that one could produce a bazillion cells and generate $1 bazillion for some company. So yeah, more discussion on that. So these are the messages, and not all of these are supported by anything I said in the talk. They're just things I put on the slide. But yeah, CORD continues to provide access for underserved patients. The new matching guidelines, I didn't say this, but I think there's plenty of evidence out there. They will lead to improved outcomes, and we need to do better at, and we've made some improvements here, but making the NMDP match algorithm highlight the cord blood units that fit the guideline and try to help people with that decision about when cord is the obvious choice, to flag that. That is something we're interested in. I just have nothing to report on yet. On the supply side, grow, but it's only viable, you know, with a higher TNC threshold. And I know some banks are doing this, so I don't mean to just lump everyone together. On the demand side, I think we need to streamline the search process and make sure the guidelines are adhered to. And I'd really love to hear more about what Anthony Nolan is doing, because it sounds like they've taken this to another level. And then, yeah, cord expansion we'll talk more about. And I think this commercial language in the consent, there's going to be more discussion about, but I think that's something a lot of intense conversation about. I think we just need to make it clear so everyone understands how it all works, and think about, as a community, what to do about this spike in demand for homozygous CBU, especially coming from Asia. So we have a HRSA registry model advisory group. We're just in the planning stages of getting the next round of matching models. But if there's something you really think should be in the matching models and you aren't in this list of advisors, come find me or one of the people in that list and try to make the case. The bioinformatics team and the Cord Bank Alliance, I've been a lot of good feedback from that group. And then I wanted to mention WMDA because I use the data, ONR because they fund a lot of this work, but also the Global Alliance for iPSC. It is an organization that is, I think, really interested in this, how to deal with all of the issues, not just the coverage modeling around these homozygous starting material for iPSC, but maybe some of the economic issues too. So I will stop there, and I think we're doing questions at the end, yeah?
Yep.
Okay, excellent. So.
Hi, I'm Gila Spitzer. I'm I'm a new section chief at Pediatric Transplant at Hackensack. I was at Sloan Kettering for many years before that, so thanks for inviting me. I'm actually going to be talking not only about about why to establish cord blood transplant for children, but a little bit of how. And thankfully, some of the previous speakers have talked a little bit about some of my earlier slides. So first, why? And why cord blood transplant should have a place in pediatric stem cell transplant. What are the indications where it may be an option amongst others, as people have said, and where might it even be considered an optimal graft? So a few cases. So a 3-year-old girl we're treating right now with AML. She presented with hyperleukocytosis, severe anemia, thrombocytopenia, circulating blasts, and she had flow that was diagnostic of AML. She has a very high-risk fusion of 98 and SD1 fusion, and she is pretty chemorefractory, having end induction MRD positivity and persistent disease after many cycles of salvage therapy. And right now, she's receiving a menin inhibitor, which is targeted therapy for her fusion, and she's had some improvement. And lucky for us, she's tolerated her therapy very well and doesn't have a lot of toxicity, because I think she will be someone who potentially has active disease at the time of her transplant. And so this is a patient that we might be talking about. is another boy. Is a little bit of an older case. It was diagnosed at 4 years old with standard risk BALL. And he was a chemorefractory patient with early high-level disease at day 8 and induction MRD positive. Ultimately achieved MRD negative remission, but relapsed early in maintenance therapy. He received institutional CAR T cells and went into an MRD negative remission, followed by consolidative transplant in his second remission, but relapsed a little more than a year post-transplant and received tisagenlecleucel with achieving an MRD negative third remission. Didn't receive a second transplant at that point, but did after his fourth relapse, 29 months later, after which he received chemotherapy and a cord blood transplant in his fourth MRD negative CR. And this patient is still in remission 2 years later. So this is someone who was multiply relapsed, chemorefractory, potentially refractory to some immunotherapy, having received 2 separate CAR T products and an allo transplant. So again, which patients might benefit from cord blood transplant for malignant indications? And so I think we've talked a lot about patients with poor unrelated donor searches. Haplos may be an option, and some centers may lean there, but they may be older, they may be ineligible, they may be less optimal donors, and so I think those patients deserve a full complement of donor evaluations. And then, again, we talked a little bit about high-risk myeloid disease, including patients who are MRD positive or are refractory, and kind of in a similar sense, patients who are receiving second transplants for relapse. And there's a little bit of a balance that you have to take with TRM and your anti-leukemic effect, but I think in pediatric patients especially, who probably have good organ function at baseline, it's something that's very important to consider. And so I first want to establish that outcomes for patients, pediatric patients receiving cord blood transplants, and a lot of this has already been said, but I'll show some of the pediatric data, they're at least as good as for other donors. And so this is a multi-center international retrospective analysis, about 300 patients, consecutive patients with AML who went myeloablative transplant from either a matched sibling, a matched unrelated donor, or a single or double cord blood unit. On the left, you can see the overall survival curves, and the 2 in the middle represent, there are actually 2 overlying there, I don't know if you can tell, represent single cord blood transplants and mud transplants. And these were statistically not dissimilar from the matched SIBs above. The bottom is the double cord blood units, and that I think was due to increased NRM, as you can see here in the middle, and the bottom kind of 3 were relatively similar in terms of NRM for matched siblings, matched unrelated donors, and single cord blood units. And then looking at the composite outcome that we frequently talk about now of GVHD relapse-free survival, or GRIFFIS, in the right curve, you can see that both single and double cord blood unit grafts had similar GRIFFIS compared to matched sibling transplants, and that's because of the very low rates of chronic GVHD in the cord blood transplants, whereas the mud transplants had much higher rates of extensive chronic GVHD, and that kind of lowered their outcomes a bit. So I think I'm also preaching to the choir that cord blood transplants are good in terms of outcomes, or at least as good as other donor sources for leukemia, but maybe we can discuss, and again, some of this has been said, for when they might be better than other donors. And so this is the retrospective study from the UK and Ireland that Dr. Politicos showed before, and you can see these were patients receiving single cord blood transplants or comparator transplants from the same time period. These are pediatric patients, and they're rather young. They're 6.5 and 8.9 years for the 2 groups respectively, and they received, this is the same time period. And so when you look at these, this is only the MRD positive patients, and so these MRD positive patients actually also included patients who were refractory, so overtly active disease at the time of transplant, and actually the majority of the MRD positive patients in this group had active disease at the time of transplant. And if you look at their event-free survival, the patients who received cord blood grafts had much improved outcomes, event-free survivals, to those in the comparator arm. And I would also point out that there were actually, and this is kind of subsumed by this information, but there are actually many more higher risk patients in the cord blood group. So this is really saying quite a bit. And this was really due to decreased relapse in the cord blood group. This was the same difference in survival was not seen in the MRD negative patients. In this same study, the benefit of cord blood versus other donor held up in the multivariate analysis with an improvement in event-free survival and a trend toward improvement in overall survival. There was definitely a much lower risk of relapse. This was somewhat balanced by higher TRM. And so there was also a benefit to chronic GVHD, and so people that survived did have good quality of life, and that Griffiths would be similar to the event-free survival. Among patients who received cord blood transplant, so all the lower rows are patients who received cord blood transplants. The only factor that really came out was MRD positivity. So patients that are MRD positive had worse outcomes than patients who are MRD negative. And most of those patients did have active disease. And this was due to a higher risk of relapse. Having MDS is a bit better than having AML, and I imagine that's because those patients are less pretreated and probably didn't have as high non-relapse mortality. And this line, I think, is actually really important, that patients who were receiving second transplants for relapse, so patients who had had a prior transplant, had the same outcome as those who did not. So that really demonstrates that even if you've had a prior allo, you still can be salvaged with a cord blood transplant. And the event-free survival for these patients who had received a prior transplant was 64%. And just working off that idea about improving outcomes in second transplants, this is a smaller report, but very newly published from 2 international centers, MSK in New York and Princess Maxima in Utrecht. And they reported on 26 patients undergoing a second or even third transplant for heme malignancy, all of whom received cord blood transplants. And although there were a variety of diseases and a variety of conditionings, you can see similar overall survivals and event-free survivals to the prior study. And they also did note that TRM was significantly decreased in the modern era. So after 2015, I think there were no TRM deaths. And to the point of single versus double cord blood units, I think at least in pediatrics, because the studies were primarily, the randomized studies were, at least the US was primarily in pediatrics, and the international study, the European study was in pediatrics and young adults. So I think in pediatrics, really, most people are using the single cord blood unit as demonstrated by these studies, and I'll just review them very quickly. So this was the US BMT CTN 0501. There were 224 pediatric patients that were randomized with heme malignancy. About a half had AML, about a third had ALL, and then there were others, and all these patients had to have adequately sized cord blood units. And they all received the same myeloablative conditioning that was TBI-based. And so you can see similar overall survivals in the single versus double units with higher rates of GVHD as seen here, with the double units compared to the single. And this is that French study that also randomized, this was pediatric or AYA patients to 0 to 35 with acute leukemia or MDS, and they randomized similarly. And so you see similar rates of transplant strategy failure with a double over single cord blood units. It's a little bit higher, but not statistically significant. No changes, no difference in relapse with the double compared to the single, but higher rates of extensive chronic GVHD. And lastly, this is a retrospective analysis, but a much larger group of 504 adolescent young adult patients who received double versus single cord blood transplants after myeloablative conditioning. And these patients also had similar outcomes in terms of survival and higher rates of acute GVHD. I think it's a bit interesting that this retrospective analysis has, each study has their own rates of GVHD that are higher. This retrospective analysis shows higher rates of acute GVHD. The European study had chronic GVHD, and in the US study there were both. But I think all in all, there appears to be higher rates of GVHD with double unit transplants. So to kind of sum up some of the malignant part of this talk, and before I move over to non-malignant indications, there are some features that make cord blood an excellent graft source for pediatric patients with malignancies. And some of these are those that have already been discussed and are not different for children or adults, but there are some that are, and as we've talked about, size is a limitation oftentimes in adult cord blood transplants, which is not the case in pediatrics. The majority of our patients we can find a single unit for. And because of this and because of the randomized trials, single cord blood units are really the standard of care in pediatrics. So I'm going to move over to non-malignant indications, and this is where I think there's differences in pediatrics versus adults. There are unique indications in pediatrics, and so I just wanted to talk about this. And I'm going to put up two quick cases. I have a 4-month-old girl with Hurler syndrome, or MPS I. She was referred based on her newborn screen at a young age. Her diagnosis was confirmed, and the genetics team started enzyme replacement therapy when she was very young, and she was referred to transplant. I'll just point out that enzyme replacement therapy for this disease is licensed to treat the non-CNS manifestations, but doesn't cross the blood-brain barrier, the CNS. It doesn't affect the CNS manifestations, and so these patients still need to undergo transplant. She did not have any sibling matches, and there was a good 8 of 8 cord blood unit that was available, and so she underwent cord blood transplant at a very young age with improvement in her disease, and now she's doing rather well. This is the 6-week-old girl with SCID, who was again referred based on newborn screening for severe combined immune deficiency. Her genetic testing identified a homozygous mutation in PNP, which is a rare form of SCID, and there was consanguinity to account for the homozygous mutation in a rare gene. And this is an enzyme that's present in red cells, and so she received many red cell exchanges during the brief period before she can come to transplant. She had one full sibling that was not a full match. She had a few unrelated donors, but they were all older and international, and this is a rather urgent indication. They would take time to mobilize, and there was a large unit that was available for her. And so she underwent cord blood transplant at a very young age, and this is standard for this disease, with normalization of her enzymes and immune reconstitution, and she also is doing very well. So I'm going to, 2 slides that are very similar, but the kind of, this is probably inborn errors of metabolism or inherited metabolic diseases are probably one of the biggest indications in pediatric non-malignant diseases for cord blood transplant, and they're a group of genetic diseases that are caused by these defective enzymes that, amongst other complications, lead to neurodevelopmental delays and ultimately significant disability and early death. And these are some of the diagnoses: Hurler syndrome or MPS I, Krabbe disease, ALD. So those are those that come to transplant. And people have been using transplant for these diseases for a long time to help these patients, and the best outcomes are those achieved when those patients are asymptomatic at the time of transplant. And I'll say in New Jersey and New York, we're very lucky because they're included on newborn screening, but that's not the case everywhere. And therefore, these patients really benefit from a very rapid stem cell transplant. And not only do they benefit from rapidity of their transplant, there are donors, there are problems using carrier donors because you really want those patients to achieve normal enzyme levels. And for inborn errors of immunity, or SCID as a prime example, again, these are patients that die early in life from opportunistic and overwhelming infection, and we've been using transplant for a very long time for this disease as well. Again, these are patients that need to be transplanted very young and very quickly so that they are infection-free at the time of transplant. And so, in the past, before there was a lot of cord blood transplanting in the late 80s. These were, and even 90s and early 2000s, these were patients that received haplo-maternal grafts just because they were available very quickly. But there are problems with this as well, and in certain enzyme-deficient patients, they may be less optimal. So for a variety of reasons we'll discuss, cord blood is actually a favored donor source for patients with metabolic diseases. And again, some of this has been talked about, but I think it's important to review. So this is a 3 kind of pronged retrospective study from Eurocord EBMT, Duke, which has a large U.S. metabolic center, and the CIBMTR, looking at 258 children transplanted for Hurler syndrome, or MPS I, from a variety of sources. The most common graft type was actually cord blood, but a lot of them were mismatched, followed by unrelated donor and matched sibling donor. And the outcomes for these patients were best when they were transplanted with when they got transplants from either matched siblings or fully matched cord blood units, and then 5 of 6 cord blood units and MUDs came second in line as long as they were done earlier in life. This is just notably event-free survival, and so many of these patients who lost their grafts were salvaged, and only 3 patients died from disease progression. And even in the modern era, so this is kind of, these 2 studies are reporting on patients with MPS, mostly MPS I, and they're showing the benefit of kind of standardization of practice. They had very specific donor hierarchy, they had very specific cytoreduction, and when you do these things, your matched transplants still come out better, but you can see that survival is much improved. And event-free survival was over 90% in patients receiving matched transplants. And again, superior survival in patients receiving, or I guess inferior survival in patients receiving very mismatched transplants. But there is a lot of more flexibility in the cord blood space compared to the unrelated donor space. And these are some of the studies, again, shown previously, that allele level matching is also very important for patients with metabolic disease, as well as kind of general and non-malignant diseases over here on the right. So this 8 of 8 and 7 of 8 cord blood units were much superior to, or were superior to some of the less matched cord blood units. Obviously, you have to grow your inventory in order to get better matched units. You can't invent them, but I think it's important to recognize. And the one kind of transplant factor that we haven't, kind of historically has not really been able to be improved. A lot of outcomes have been improved by harmonizing best practices in terms of cytoreduction and graft selection, but reduced intensity conditioning always was associated with poor outcome. And we really like to reduce conditioning intensity in patients for non-malignant indications. You are not trying to use chemotherapy to cure their leukemia. And so, any additional toxicity is unnecessary toxicity. And so this is a novel reduced intensity regimen using kind of distal combined immunosuppression and myelosuppression to allow robust engraftment of cord blood units. And you can really see excellent outcomes at a year and even at the 5-year time points. Many of these were mismatched units. Majority were 5 of 6 and 6 of 6, but more than half were less than 7 of 8, which we know is associated with poor outcomes. And so this is really a very nice platform to kind of engraft patients with non-malignant diseases with cord blood grafts, which are better for them overall. And the cord blood units are favored, and as demonstrated in this paper and previous papers, because they also have better engraftment in terms of donor chimerism and enzyme levels, which are really important for a lot of these patients. So I hope I've convinced you that these are excellent and optimal donor sources for children with many non-malignant diseases. And to kind of round things out, how are we going to establish this for children, and what considerations should we be considering as we do so? And I'm not going to talk in detail, but I'm going to touch upon the things that are important. So your cord blood search for malignant patients, which patients should be getting searches, should all patients be getting searches, should only high-risk patients, poor searches, some combination, for non-malignant conditions, for inherited metabolic diseases, basically everyone should be having a cord blood search, even if they have a matched sibling, because their sibling has at least 50% chance of being a carrier. But for other diseases, we often reserve it for patients with poor donor searches. Should that be the case? Should we be looking more broadly? And so we should kind of establish donor hierarchies to treat these patients with. In terms of graft selection, what's the best unit for a particular patient. So, you know, the optimal unit for a malignant transplant is very different from the optimal unit for a non-malignant transplant. So you need to know what you're treating. The size of the unit matters, the TNC, the CD34, the banking accreditation, unit licensing, and always having a backup unit. The stem cell lab and support, I won't speak that much to this, but this is certainly an important part of the process. And the clinical care is something I do want to talk about for 1 minute, and say that treating these patients can be very rewarding, but it can also be very complicated. You have to figure out what conditioning, you know, the standard conditioning, but if you're trying to reduce your conditioning, do you use myeloablative conditioning, reduced intensity conditioning? How are you going to get in the graft? Are you using serotherapy? Usually not, but if you do, to use it very carefully. Donor-specific antibodies. They can have unique presentations of common complications, such as GVHD and unique management. Patients with non-malignant conditions have unique complications that are well described but uncommon in malignancy, such as hemolytic anemia post-transplant. And so it's really important to kind of lean on experienced clinicians who can guide you and collaborate with an experience center if you don't have such experience yourself. And again, we've talked about guidelines. There are guidelines for donor and unit selection. There are guidelines for practice. But you know, it's difficult to put everything down on paper very succinctly, so collaborating with expert centers is really important. And with that, I will thank my current colleagues and most importantly my former colleagues who have, Dr. Makis Kardavou has taught me most of what I know about cord blood transplant, Juliet Barker for inviting me, and all the support staff without whom we could not do this work.
Okay, Joanne, I think we've got about 20 minutes for discussion, questions? 19, okay. So listening to all of this in this morning and sitting there thinking about it, I think that you know, the transplant centers potentially sort of due to all the dynamics that we've been talking about will decide whether or not they're going to embrace cord blood or not. And the transplant physicians that are going to embrace cord blood, they're sort of one entity. And so, you know, at the end of the day, you know, one center may say, I like doing it like this, another center may say, I like doing it like that. But to be able to move forward, we will probably be able to reconcile that. And I think from the standpoint of the banking and the size of the inventory and unit selection, I think that's much more complicated, because of the fact that I hear a lot of different things, and when you think about it, there's a lot of people or a lot of entities involved. So you've got the government that funds, you've got the banks, you've got the NMDP and other registries that facilitate the selection and shipment of the grafts, and then you've got the transplant centers that select the units. And how you're going to resolve all of that, I think, is going to be a major hurdle for the field. And I think it is the elephant in the room to be able to move forward. And you know, I would be interested in sort of further discussion about that. And just for entertainment, and then Filippo's going to ask his question. I was in Australia recently. And when you go to Australia, what's terribly reassuring is that there's good stories about, you know, who's been sort of attacked by dangerous animals. So quintessential Australia, there was, a couple of months ago, there was 2 military men in northern Queensland who wanted to go swimming. And the locals said, don't swim over there because of the fact that you're going to get attacked by crocodiles. So at any rate, they went swimming at that spot where the locals said, don't swim, and they got attacked by crocodiles very badly. And so now there's a big controversy in Australia about who's responsible for the crocodile attack, and with some questions of significant liability. And I was sort of reading this, and you can Google and watch how this is unfolding in the media. But the point being, I thought, this is like cord blood, because of the fact that if you say the crocodile attack was sort of an adverse event of swimming, and these people didn't listen to the local experts that said, don't do this. Now, if you think about, let's say for the sake of argument, that a transplant center does a cord blood transplant and there's a graft failure, and it actually relates back to the fact that the graft was of poor quality. Then the question is, who's actually responsible for that? Because as a field that we need to grapple with this, and I don't think that we've done it. So is it the transplant center that selected the units? Or is it the registry that facilitated the units? Or is it the bank that actually permitted those units to be distributed? Or combinations of above? And this is a provocative statement, but I do think that this is an issue that we're going to have to get our heads around. And I just thought that I'd throw in that anecdote, but given that I was recently in my home country. And I think that different people would say in terms of the size of the inventory, completely different things. And there are elephants in the room in terms of, you ask the transplant center physicians, they will prefer some banks over others. So quality is a big deal. So on that note, Filippo's going to ask a question.
First of all, when you go on vacation, you should not think about cord blood, but it's okay. That's your problem. But so if we look at the presentation that Sharon gave this morning, right, about haploidentical transplant, one thing that really comes up is the fact that the rising of haplos is due to the fact that it's a very easy platform, easy to replicate, and can be done pretty much everywhere, and mainly is due because of the use of PTSI, right? So we all agree on that. When we talk about our field instead, Juliette, is the fact that if anything, we have complicated things, and you said that in your slide that expansion somehow has not make things easier because you still need to have some resources to do cord blood expansions, and now we have companies that do it for us, but it's definitely not make things easier. But at the same time, I think we should look at ourselves, and I think all this presentation points out towards something that we do see low relapse rate with cord blood. We have attributed that for a longer time a double cord blood transplant, but I'm not sure that is the case. I do think that we use conditioning regimens like with high-dose DBI that really helps. We are trying definitely to be more uniform, using your regimen more and more in many centers, which I think it's a good thing. But I think we should ask ourselves, and I would like to hear your comment and also the comments of the other speakers, about the fact that maybe we should rethink about the use of double and considering doing more single cord blood transplant, because it will make things much easier for the centers that have less expertise. Instead of choosing 2 units, you need to choose 1 unit. As long as it's a good unit, I think you can have the same outcomes.
There's a lot to unpack there. Maybe, but I would take back to what what Yanni just said in relation to the very unique biology of cord blood transplantation, at least in the malignants. And about sort of complicated sort of graft versus graft and augmentation of graft versus leukemia effects, because personally I think that is real. There's also the question of unit quality in terms of, now we can have a backup graft, but nonetheless, not all the units are the same. And sometimes the beauty of the doubles, to be perfectly honest with you, is that you put in 1 unit and it's not as good quality, and the fact that you're putting in a second one is the sort of backup. So I certainly appreciate your comment, and I do think it is a little bit complicated, at least in the adults with malignancies. In the pediatrics, it's a different question entirely.
Yeah, but the data that come from Japan, though, if you look at Japanese data where they keep doing cord blood transplant, their data is all on single cord blood transplant. So I do think that actually if we can revisit that as a community, I'm not saying it's going to solve the problems, Juliette. Maybe we're going to deal with the same problems, but I do think it will make things much easier and maybe considering cord blood a little bit more acceptable because it's going to be seen a little bit less complicated.
Yeah, I would argue that there's some other ways that we can make cord blood transplantation easier, and I also would argue that the patient population for adult malignants, for example, that we're transplanting in New York is not the same as the patients that are being transplanted in Japan. Next question.
Hi there, Roger again. Just a quick comment actually off the back of the WMDA data, because it always shows this decline in cord blood usage. Is that what we're really seeing, or are we seeing a shift away from double transplant to single transplant? Because I can say in the UK this year, 58 patients treated, only 8 of them have actually been double cord transplants. So are we just seeing a big shift to single? And if that data displayed number of patients, would it actually be a flat line or even possibly an increase? Has anybody got any data that might suggest that, other than our little island?
I think I think it's a valid question. I don't have the full answer, but I think this is an absolutely longer conversation.
I mean, it doesn't help us financially, but certainly in terms of maintaining the skill set, if there is an increasing number of patients requiring it, it's definitely food for thought.
Yep. Leyland.
Thanks, Juliette, and thanks, everyone. Great talks. I would like people to comment on potentiation of the GVL effect in cord blood transplant and what they think is in the future. I mentioned it in my talk, but specifically how you think we can leverage the strength of cord blood transplant even better than what it is right now. So working on like Rob Wynn's maybe platform or other things. So if you could comment on that, that'd be great.
Right. I'll let Yanni say something, but before Yanni speaks, I think the ability to be able to basically get the, like, when I see a new patient, I want the weight and I want the typing. And then sort of a bonus would be to be able to get the ancestry of the patient and then plug it in and see what you've got. And then you can see the patient and see what the related donor situation looks like, and sometimes the related donors have been typed. And for high-risk disease, you can go to transplant potentially within less than 2 weeks. Like, there is no other stem cell source, including match-sibs, that you can do that with. And I think it is completely underutilized in terms of the high-risk malignants. And in terms of the biology, there's a slew of things to say, which Yanni's going to answer.
Yeah, I will make a comment that I think it's also relevant to the question that Filippo asked. I think the problem with understanding whether the double has a benefit is we don't know the exact biology. But there is the notion that the graft versus graft interaction may be doing something, because the data from Rob Wynn, where they throw in the granulocytes, and then they cure refractory leukemias. There is data from China where there is a haplo-cord platform, but designed so that the haplo engrafts long-term, not the cord, and yet there is still lower relapse. So there may be something happening with the graft versus graft interactions. I don't remember if there was a difference in the relapse signal in the randomized NOLA trial. So maybe we don't know what are the cells or what are the immune reactions that may be benefiting GVL when more than one grafts or more than one products are combined. I will say that when we had done double cord haplo trial, we certainly had some suggestion of more immune reactivity, more PES, maybe a little more grade 2 GVHD. The relapse is low regardless, so I don't know if that made an additional benefit, but understanding the biology of graft versus graft interactions and how those may lead to GVL, I mean, I think that will be important, but there is a gap right now. and the knowledge.
And the thing is that the funding's fallen out, so the fact that we wanted to pursue, big research of this very question, like, over a decade ago, and with the PT-side plus the CARs, the funding just dropped out, basically. And yet, I completely agree with Yanni. I mean, you can take people in with absolutely horrendous disease, and you've got this molecular remission on day 30, and you just think, hey, it's not the prep. Mm-hmm. It's the graft. Although with the mini, you wouldn't be able to pull it off for sure. So I don't think we understand it. But in relation to the question and the Rob Wynn data, if you had a good single, I've always wanted to do a trial where you could take if we understood this as a, cellular product, like a PBSC, whatever, from a donor that has a specific HLA, irradiate the cells, and then just throw them in. You're sort of basically vaccinating the single unit graft.
Yeah.
I think there's a lot of scope here, which is, I think, what you're pointing out.
Thank you.
I have a comment on biology of the cord bloods, because you can't recognize when you get a high TNC unit or a high CD34 count, whether the cells are really coming from a unit who has sufficient cycling cells, for instance. Cord blood is the only source besides some bone marrow stem cells who are resting cells. So, and if Hell would be in the audience, he would also support the philosophy that to inject cycling and non-cycling cells is the best you could perhaps do from a biology for a patient if he is heavyweight. Because the non-cycling CD34 cells, which are really the stem cells, they need a longer time. So you can solve this problem by double cords or by expanding one cord per unit. But at the end, it will be the resting CD34 cells who will engraft long time. And this is an argument for me in heavyweight patients to do double. So to have the biological advantage of both cell types.
Right. And are there sort of immunologic aspects, getting away from the stem cell biology, are there immunologic aspects that would make one unit sort of separate from the HLA match advantageous? Colleen?
So I think we're hearing a lot of common themes, and this whole issue of ease, I think, is incredibly important. Juliet, you focused on that in your talk about how to make cord blood transplant more accessible, right? We have to make it easy. And a lot of perception around things that aren't making it easy. I actually just want to point out one thing, though, because we were talking about the graft versus graft and all of these things, and what you just brought up, Juliet. Filippo is running a study right now that is a single cord blood transplant study using our pooled donor derived HSPC product. And it's very similar to what Rob Wynn is doing, except easier, right? So again, if you have something that's cryopreserved in the bank, and it's 6 to 8 different cord blood donors, and it is that idea that that product is not to last forever, but it is to enhance a GVL. And I think it would be great, again, it's a common theme here, right? How do we do single cords? How do we, if you're doing a double cord just as a backup, like you said, it's just a backup, to make sure that I get a graft in, maybe that money should be spent for that second cord on some of these other types of approaches. Mm-hmm. But I'm going to, hopefully, Filippo, that data will be available next year. But I think that could be a really important study.
Absolutely.
To show this.
And in that setting, I would want a optimal unit because I'm relying on that single having good post-thaw CD34
but I think that's the beauty
of
the quality, right, that everyone's talking about. The banks and the quality is getting better, and I think that's enabling us to do, more confidently do singles. The other thing I just wanted to say is I think it's really interesting that the cord blood community has not marketed ourselves as well as the haplo community has. And I know we've talked about this in the past too, but this idea of, when we talk about cords and everyone's like, oh my God, they're not going to engraft, or they're going to engraft at day 20, or it's like this litany of all of these reasons why not to do a cord. But with haplo and the advent of, PT-Sci, I mean, what's the average time to engraftment? I don't know, something like 16 to 20 days, depending on if it's peripheral blood or a bone marrow graft. But they didn't get up and say, hey, we're delaying engraftment by giving PT-Cy, right? And I feel like we're always on the defensive and making excuses as opposed to embracing what we have. And cord blood transplant recipients now...
It's exactly right, because of the fact that the mini prep is not a good prep for high-risk myeloid diseases, for example, and a haplograft, because they'll relapse. But you jack up the intensity of the prep, it starts becoming much, and then you throw in PBSC, it starts getting quite a little bit more complicated. I completely agree with you, but hence the question of proving through a network of collaborating centers that this is actually, there's a lot here to like. Hence my point, and I think your point too.
Yeah, and making it easy, is key.
Well, I wasn't going to respond to that. I was just going to ask about the cord blood clamping and milking, and if we've seen a difference in the cord blood products. It didn't seem like it from that presentation, but there's been recent data that neonates, do better if they're hypoxic or have other adverse effects with cord blood clamping, and I'm wondering if that's going to affect our collection of products.
Who wants to take that one on the banking front? Yep.
So yes, clamping affects cord blood volume and cord blood cell dose, and Maki, actually from Maki Skaradova from New York Blood Center, did and published a nice study showing that for every minute you clamp after 60 seconds, you lose 10% of the volume in the cells. If you clamp for 30 to 60 seconds, you lose less. And the recommendations from ACOG are to clamp for 30 to 60 seconds, not longer than that. So, yeah, there's many things that have disadvantaged cord blood, and clamping is one of them, but at least if you can recommend to follow the ACOG recommendations, there's a minimal effect on the overall cord blood volume and cell count.
But I think to sort of finish off the session, because we're
at
I think about time. In addition to that, there's also, like, when you do searches all the time for large patients that have more exotic HLA, you can see how the inventory morphs. The big question is for each individual bank, where's the money coming from? To be able to fund their banks. No, I'm serious. You can see the banks that are funded in certain ways that are getting bigger and bigger and bigger. They're starting to take on the sort of certainly at Sloan, the sort of lion's share of what units that we're shipping. Whereas banks that, for example, that we used to use all the time, but they stopped collecting, their large units are just sort of disappearing, and so they don't have enough units left that are big to select. And so, I mean, yes, the delayed clamping is just sort of doesn't help, but it's also a question of how are the banks actually operating and how are they funded. And what's happening is that you're seeing banks fall away, and then some banks are cleaning up, and that's sort of the nature of the beast.
So wait a minute. I mean, funding a public bank is very difficult. No one makes money on a public bank.
That's my point.
And the banks that are surviving are not running away with anything. They're just surviving, and they've gone through whatever alternative creative funding mechanisms to stay alive. HRSA, which provides through the C.W. Bill Young program and the legislation from 2005, subsidizes licensed public banks under very certain conditions, and that's a huge help for the banks that have that funding. But it's a labor of love and a public service, and it is not, no one is running away with the bank.
I
Literally
completely
or
appreciate
figuratively?
that, but as a user, this was not a criticism. This was an observation that the transplant physicians want units there to be able to transplant, because if units disappear, then you know, I'm retiring.
So to that 150,000 number, which was 2005 when that number was put into the legislation, you know, the real number is something very different, and it's about replenishing the bigger, more robust units, which has to be an ongoing operation, so to speak.
Absolutely.
And it's not really whether it's 150,000 or 50,000, it's keeping those large units available.
Absolutely.
Anyway, I think we should stop for lunch and
Lunch.
continue this conversation.
Thank you.